Good evening, ladies and gentlemen. Today we have the last of the series of webinars that have been brought to you by the South African Dental Association and the South African Society for Periodontology, Implantology, and Oral Medicine. This was for the month of September, which is Oral Health Month. The series as a whole has had great support from our members, so we thank you for that. And oh, it's only now. Good evening, ladies and gentlemen. Today we have the last of the series of webinars brought to you during the month of September by the South African Dental Association and the South African Society for Periodontology, Implantology, and Oral Medicine. September being Oral Health Month. The series as a whole has had great support from our members, and we thank you for this. It has also provided exposure to our registrars from each of the universities within South Africa. Just some standard announcements. Please refrain from using the raised hand, but type your comments and questions in the question and answer tab. CPD certificates will be loaded to the SADA platform, and you will be able to access all the certificates under your member profile. If you're not a SADA member, you'll be able to create a profile for yourself and access your CPD certificates. The event for tonight qualifies for 1 clinical CEU, and we are streaming live on YouTube, just in case you have difficulty to access the Zoom platform. A reminder also to complete the evaluation after the webinar. I'd also like to remind you of the upcoming webinar on the 30th of September, PPS, Ms. Tamsin Gradwell, SADA and PPS estates and wills that will be discussed. Tonight, our speaker is Dr. Zamansele Njoko, who I know quite well as a registrar training in the university at WITS, in the department at WITS, of which I was a part of not too long ago. Dr. Njoko is from the same province as I am, Kwazulu-Natal. She was born in Ladysmith and obtained her Bachelor of Dental Science degree for the University of the Witwatersrand in 2012. She is currently a registrar in Oral Medicine and Periodontology at WITS, and has completed a course in periodontal plastic and aesthetic surgery. In her spare time, she practices as a pastry chef, something I didn't know, but if I had known, I'm sure I would have taken more advantage of. So without much further delay, I hand over to you, Dr. Njoko, who would be speaking on sarcoidosis this evening. Thank you.
Thank you, Dr. Mia. Okay. Good evening, everyone. Thank you, Dr. Padayachee, for the introduction. Thank you to SASPIO and to SADA for the platform, and to the audience for making the time.
Sorry, Zama.
Yes, sir.
I just want to, I think your presentation is not being shown. What we see is the desktop. Yes, thanks.
Can you see it now?
Yeah.
All right, thank you.
All right, thanks, Zama.
My topic for this evening is sarcoidosis, case presentation, and review of the literature. I will start by presenting my case, and then this will be followed by a literature review. So my patient, a 44-year-old female, came in with the main complaint that read as follows. My lips are swollen and feel heavy. The swelling comes and goes with no associated pain. My tongue has also developed cracks and presents with pain to spicy food. Now, in the history of the main complaint, the patient mentioned that the fissuring of the tongue and the buccal mucosa, which we'll see in subsequent slides, first presented in 2013, and the swelling on the lips started in 2014. Now, in the medical history, my patient is HIV positive. She was diagnosed and initiated on treatments in 2013. She takes a single drug, which is a combination of Bacava, lamivudine, and alluvian. So Bacava and lamivudine, those are non-reverse transcriptase inhibitors, and alluvia is a protease inhibitor. In her CD4 count and viral load, which were taken in August of 2020, the CD4 was 833 cells per microliter, and the viral load was lower than detectable. Her CD4 was well within the normal range, which is between 332 and 1,642 cells per microliter. She further reported that she sometimes experiences stomach cramps, and from the drugs she takes, lamivudine and alluvia are known to cause abdominal pain. Okay. So this is the extraoral presentation of the patient. She presents with diffuse papules that also form plaques, which were hyperpigmented, and they were quite diffuse in the face and the neck. So she reported that she's had these from a young age. However, as the condition started around 2013, then the presentation, it became more pronounced to what it is currently. So further to this, the patient also presented with macules that also formed patches on her hands. So this had a purple color and there were no symptoms associated with it. So she further relayed that the presentation also started around the time that she noticed the changes to the orofacial region. Okay, and then in her lips, so she has swelling of both the upper and the lower lips. She also has, well, the lips were dry with atrophy in the center of the lower lip. She also had vertical lines presenting on the lower lip. And on the corners of her lips, the corners of her lips, yes, she had a crusting, which presented on those sides. And then on palpation, both lips were firm, but they were non-tender. Okay. And then in the intraoral examination, so in the buccal mucosa, there was the presence of prominent lines, which formed a cobblestone appearance. It was more pronounced on the patient's right-hand side. It is somewhat more subtle because the mucosa was stretched as the images were taken. And then on the dorsal, on her tongue, so she presented with a dip fissure, which she referred to in her main complaints as well. So the dip fissure in the center, and also she had enlargement of the tongue, and it had diffuse wide areas, both on the dorsal and the ventrolateral aspect. And further to this, we can appreciate the poor oral hygiene, drifting of teeth, carious lesions, and the erythema with which the patient presented. Okay. And then this is just an occlusal image, and from this we can appreciate the erythematous patch, which presented on the hard palate, and also the poor oral hygiene that is evident. So this was her panoramic radiograph, which was taken on the 10th of December in 2020. And from this, so it's mainly a horizontal pattern of bone loss that presents drifting of teeth, carious lesions, and even a retained root. Okay. So from the information we have thus far, in the differentials, we had Crohn's disease was one of the lesions. And this was mainly due to the orofacial swelling with which the patient presented, and also the fact that she reported the presence of stomach cramps. So Crohn's is known primarily to involve the intestine, the colon as well, and it extends anywhere from the mouth to the anus. Another differential we had was orofacial granulomatosis. So typically with OFG, how it presents is the patient would have orofacial swelling without any systemic involvement. Another differential we had was sarcoidosis and other granulomatous lesions such as TB, and even Wegener's granulomatosis could also be differentials. And the last one we had was angioedema. So this was mainly due to the swelling with which the patient presented. However, in angioedema, it tends to have an acute onset. However, there can be recurrent cases which present with a chronic nature. So after this, the patient was then sent for a chest radiograph, and blood tests were performed as well. And then, so this is a posterior PA chest radiograph. And from this, we can appreciate the enlarged mediastinal lymph nodes, which are pointed with the arrows, and the calcifications that present as well. So the enlargement, or the area where the arrows point, those just signify the presence of the bilateral hilar lymphadenopathy, which is a finding that is common in lesions of sarcoidosis. So a chest radiograph is also helpful in excluding the presence of tuberculosis. And what would happen, the difference in TB is that often the calcifications, they would be more diffuse, or they could be scattered radiopacities, and the combination of the two together is often referred to as a cone complex. Also, what could be noted in tuberculosis, which is different to sarcoidosis, is that they could be the presence of pleural effusions. Okay. So blood tests were further performed, and what was striking was the angiotensin converting enzyme, which was elevated. So it was 92 units per liter, and the norm is often 8 to 52. So the elevated serum ACE is also another marker which is used in the diagnosis of sarcoidosis. So after we had obtained all these diagnostic aids, we then elevated sarcoidosis to be the main differential diagnosis. And then also in this visit, what we did was that a smear was performed on the dorsal aspects of the tongue and also on the hard palate. Okay. We also performed an incisional biopsy. So in performing an incisional biopsy for sarcoidosis, ideally you want to ensure that you have adequate depth. So you want your base to be broad-based, because so like the granuloma formation is often seated deep within connective tissue. So you don't want to take a sample that would be inadequate. So we took the sample and it was sent for H&E. And then this is how the patient presented 2 weeks after the biopsy was performed. And then, so this was the smear for the report for the smear which we had done. And it reported presence of Candida hyphae. So the patient was then prescribed metronidazole gel, 20 milligrams, which she used for a period of 2 weeks. And then, so this was our histo report. And what is striking from the reports was the presence of the epithelial itself, and also the absence of the acid-fast bacilli. Excuse me. Okay, so with this report, it then excluded the presence of TB, and also no fungal organisms were identified within the specimen that was submitted. And further, the specimen reported on the presence of non-necrotizing granulomas. Okay, so after we had received the histo report, we then referred the patient to Bara Dermatology, where she was managed and further diagnostic tests were performed. So the patient was initiated on doxycycline at Bara, and this image, it just shows the presentation after we had performed the biopsy and 2 weeks after the patient had been initiated on the doxycycline. And from this, she reported being happier, more comfortable with her appearance, and that the swelling had regressed somewhat. Okay, and then again, these are the changes to the buccal mucosa. So we still have the prominent line which created the cobblestone appearance. Yeah, so it is somewhat a bit more subtle in presentation compared to how it was initially. And the fissure on the dorsal surface of the tongue is still present. However, the patient said she's now more comfortable with her tongue and she consumes spicy food without experiencing any discomfort. Okay, so now we move on to our literature review. So sarcoidosis, it's a multisystem granulomatous disorder of unknown etiology. And it often presents as non-caseating or non-necrotizing granulomas. However, in literature, there are a few cases that have been reported to present with necrosis. And then it also has a bimodal age distribution. So the first incidence of sarcoidosis is noticed between the ages of about 25 to 35. And then the second incidence occurs in older individuals, often between the ages of 45 to 60. And it is most prevalent in the United States and also in the Scandinavian countries. So I mentioned that the etiology of sarcoidosis is not known. However, there are certain bacterial species that have been associated with sarcoidosis. And one example is TB. So in many of the specimens of sarcoidosis that have been submitted, what was found was the presence of TB DNA or RNA. So this signified the possibility of it playing a role in the etiology. Propionibacter agnes was also one, and human herpes virus 8. Environmental factors such as wood, dust, silica, insecticides, pollen, and even mold. And lastly was a genetic predisposition. So with this information, it's important with history taking to be thorough in your assessments and the questions which you pose to the patient. You'd want to inquire about a history of TB. So you'd want to ask your patient if they've experienced any cough, night sweats, weight loss, dyspnea, which could allude towards a possibility of TB, and even inquire about family members or contacts that they could have come across who may have had TB. And with the environmental factors, with those, so again, you'd want to inquire about travel history, the type of job the patient does, or even certain areas that they may have lived in, which again could have posed some exposure to some unknown antigen. And then with the genetic predisposition, so this has been associated to certain human leukocyte antigens, or even single nucleotide polymorphisms in your inflammatory cytokine. And the genetic predisposition is further supported by the fact that sarcoidosis tends to occur in families. So in classifying granulomatous lesions, different classification schemes are used. So you can look at the granuloma if it's cell-mediated or foreign body, the etiologic factor. So how I've classified it is the broad categories whether it's caseating or non-caseating, or whether it forms central necrosis or not. And for sarcoidosis, as I mentioned, that the etiology is unknown, and it falls under non-caseating granulomas. And then under the caseating granulomas, often what you'd find is that there would be like central necrosis in the center of the granuloma. And one condition which most of us are familiar with is TB. Okay, now we move on to the pathogenesis of sarcoidosis. So sarcoidosis is often, it occurs as an immune response to an unknown antigen. So your antigen presenting cells, this could be macrophages, your dendritic cells, or even your Langhans cells, would present the antigen to your naive T cells bound to the MHC2 complex. So as it binds, your T cells are then activated according to, or like under the stimulations of cytokines that are present in the environment, and they differentiate into T helper 1 cells. So these cells would then secrete cytokines such as your interleukin 2, interleukin 12, your tumor necrosis factor, and interferon gamma. And then what would happen is that there'd be formation of a granuloma. So your macrophages would clump up together, forming the epithelioid cell. You'd also have the presence of Langhans giant cells. And in the periphery of your granuloma, you'd often have the presence of lymphocytes. Okay. Now, in sarcoidosis, so for full function of your T cells, you require a second signal, or a co-stimulatory signal. So this comes from the interaction of the CD28 receptor on your T cells with the co-stimulatory ligand, which is present on your antigen-presenting cells. So this ensures adequate functioning or full functioning of your T helper cell, and also enables them to be activated and to proliferate, and preventing anergy as well. Now, in chronic lesions of sarcoidosis, what we often find is that the second stimulation is often weakened, so your T cells are not fully activated. Okay. Now, we mentioned that sarcoidosis is a multi-system disorder. And so what would often present is that the pulmonary system or your lungs would be involved. And as we had mentioned earlier, that there's often the presence of bilateral hilar lymphadenopathy. However, in about 30% of patients, this is just an incidental finding, which presents on radiograph, where the patient wouldn't have any symptoms. However, chest involvement in sarcoidosis is the most common finding, and a patient could present with dyspnea. They could present with a cough or even chest discomfort. And as we mentioned earlier, that it is important to acquire a chest radiograph, again, just to exclude the possibility of TB. Okay, so sarcoidosis could also present cutaneously, and in presenting, it could present as erythema nodosum, where you'd have like skin elevations which could be blue in color. They are often non-tender. Or it could present as lupus hernia, which is what we see in the image. So with lupus hernia, it often presents on the nose, the cheek, or even on the extremities. And it presents as plaques, which could coalesce to form, it presents as papules, which could coalesce to form plaques. And the color, so it could be a violet, a purple color, as is present in the projected image. Okay. And then there could also be oral involvement. Now with oral involvement, it's non-specific to sarcoidosis. So the presentation, it varies among the different granulomatous lesions, but it could present as papules or even nodules, as is present in the first image, or it could present as a granular patch, an erythematous granular patch, as we can see in the interdental region between the two incisors. So again, they could be mucosal ulcerations, they could be enlargement of the lips, as was the case with my patient. There could also be cobblestoning of the buccal mucosa, or even a linear presentation in the vestibule, which could also ulcerate with time. Okay, and then further to this, okay, so within the salivary glands, the minor salivary glands are the ones that are involved most of the time. However, there could be involvement of the parotid gland, which could either be unilateral or bilateral, and patients would often present, they wouldn't report any pain. So it would just be a painless enlargement of the gland, and this would be due to infiltration of the granulomatous lesion within the ductal space, and it often obstructs the duct, leading to xerostomia in patients. Okay, so still within the oral presentation, there could be radiopacities which could present within the mandible or the maxilla, or even bones in other areas as well. So this would erode the cortical area without causing any bony expansion. Now in the mandible, what we'd find as well is that there could be the presence of mobility that comes with the bone destruction. So other systems that could be involved are the eyes, where there could be presence of uveitis, the hepatic system as well, where there'd be presence of granulomas presenting. Yes, the presence of granulomas, excuse me. Okay. Now, Excuse me.
Zama, do you wanna have a glass of water, maybe just a little?
I think I'm okay now.
Okay, all right, thanks.
Okay. So hepatically, again, patients would just have the presence of, excuse me. Okay, so there'd be presence of granulomas, and so this could go undetected when performing your liver function tests and other systems. Other systems that could be involved. Dr. Padayachee.
Yes. Would you like to just take a little break and have a glass of water, I think?
Yeah.
Is that okay? All right. We could just excuse Dr. Njoko for this, just so that you can have a glass of water. Okay, welcome back, Dr. Njoko. You can
I'm back.
take the stage again. Okay.
Yeah.
Thanks.
Okay, so the other systems that could be involved would be the cardiac, the neural, or even the renal systems. Okay. So in the diagnostic criteria of sarcoidosis, none of them are pathognomic for sarcoidosis. However, the presence of non-caseating granulomas, a chest radiograph, which would reveal the presence of bilateral hilar lymphadenopathy and the elevated serum ACE.
Sorry, once again, I think we'll just wait for Dr. Njoko to just have, to just catch a breath.
Okay, so the non-caseating granulomas, the chest radiograph showing bilateral hilar lymphadenopathy, and also the elevated serum ACE levels are often the main criteria which are used in the diagnosis of sarcoidosis. So other criteria include the soluble interleukin-2 receptor, pulmonary function tests, and elevated bronchoalveolar lavage lymphocytosis, which often reveals an elevated CD4 to CD8 ratio, and also liver and renal function tests. Now, with the ACE, what we should know is that it's not like it has a low specificity and sensitivity because it presents in other lesions such as diabetes mellitus, in cirrhosis, or even in leprosy as well. So in the management of sarcoidosis, often you allow a 3 to 12 period waiting month just to see the cause of the disease. However, there are cases that often warrant immediate treatment, and such are when you have cardiac involvement, renal involvement, ocular involvement, which does not respond to local therapy, where there's renal complications or even organ dysfunction. Okay, so in managing sarcoidosis intraorally, often you take the patient through a cause-related phase where, particularly in my patient, she presented with oral hygiene. So you'd want to modify her brushing habits and take her through the cause-related phase, perform supra-subgingival debridement where required. She also had presence of carious teeth. And as we mentioned, that patients often present with xerostomia. So this could be a common finding. So for teeth that require extractions or restorations, this will be performed accordingly. And the mobile teeth will be splintered, but obviously this would have followed a cause-related phase, removing the etiologic factor. And they could be, like, you could also implement the use of salivary stimulants, topical fluoride, or even antifungal medication. Okay, and then pharmaceutically, so corticosteroids are first-line therapy drugs, which are used in managing sarcoidosis. And so they tend to suppress the inflammatory response and decrease the release of cytokines as well. But with the long-term use of corticosteroids, they're associated with side effects. So ideally, you wouldn't want to use them long-term. And often, as you discontinue the use, patients would often experience a relapse in the condition. So other drugs which are used are immunosuppressive drugs, such as your methotrexate and azathioprine. And these are purine synthesis inhibitors. So they will inhibit like your T and B lymphocytes, decreasing the inflammatory response. And yeah, they are used often in cases that may be refractory to corticosteroids as well. And then other drugs, such as your antimalarials, an example would be fluoroquinolone, which is bactericidal. It inhibits DNA synthesis. Now with fluoroquine, you don't want to use it long-term because it's known to have side effects such as retinopathy, and that could cause blindness in the long term. And in patients that are given fluoroquinolone, ideally you'd want to monitor and check for the eye function at every 6-month interval. And then the last one, biologics, and an example is infliximab, which is a monoclonal antibody that is effective against tumor necrosis factor. Now, where you give biologics, ideally you'd want to make sure that you've excluded the presence of conditions such as TB, because if it is present, maybe in a later form, it could reactivate. Okay, so my patient was given doxycycline, and how it acts is that it inhibits T-cell proliferation and also inhibits the formation of a granuloma. Okay. So in the prognosis of sarcoidosis, about 60% of cases tend to resolve spontaneously without treatment, and 4 to 10% of patients would often experience extensive involvement of organs such as the pulmonary, cardiac, or central nervous system, and this could even lead to death. Now, again, I think what is important with sarcoidosis is that it can't be managed just by us as dentists. There has to be a multidisciplinary approach in managing such patients. Thank you.
Thank you, Zama. You can catch your breath, and I think have a little bit more water. We have a comment. Don't you have anything stronger than just water? So yeah, thank you for that interesting presentation. Yeah, sarcoidosis, a patient presenting with many many different manifestations in the same patient. So sarcoidosis is a great mimicker. So let's get to the questions. Well, let's firstly, there's an anonymous attendee who says, thank you for a great presentation. And we also have good attendance tonight. There's 220 participants. And another good comment, informative presentation, thank you. One of the questions is, are there any studies linking sarcoidosis to Roundup? And I think Roundup is a pesticide or weed killer. So are there any studies linking sarcoidosis to Roundup?
So I haven't looked at that, Doc, but I think it's worthwhile going to it. Maybe there's something to I could find from that. But among the factors that have an etiology in the development of sarcoidosis, insecticides are mentioned. And I guess in one of the articles I read for my presentation, they just mentioned that it is important to interrogate that background of the living conditions, the type of job a patient does, and perhaps those could give clues as well to certain exposures that could be like that they may not be aware of.
Yes, so yeah, I would agree. Obviously, perhaps you wouldn't know specifically Roundup, but there are studies obviously linking insecticides to sarcoidosis being an environmental factor, but obviously, you know, there's also susceptibility that might be in place as well. So the next question, which I'm sure we can anticipate in this climate, have there been any documented cases of sarcoidosis resulting from exposure to the spike protein? So I assume the spike protein there is in reference to the mutations associated with the COVID-19 virus. So
Okay.
have there been any documented cases of sarcoidosis relating from that exposure? And another one related to that is, what are the clinical guidelines on vaccination of sarcoidosis patients against COVID-19? So maybe you could address each one separately.
Okay, so with the relationship between sarcoidosis and COVID-19, sarcoidosis is known, like its primary involvement will be the lungs or the pulmonary system. So often in patients who would become infected with COVID-19 in the presence of sarcoidosis, they tend to have a severe form of, like, the outcome of symptoms is more severe than in individuals who wouldn't have the presence of sarcoidosis. And again, they tend to present with other comorbidities and the fact that they are taking immunosuppressives. So the disease process, it tends to be worse in such patients as compared to a normal individual without sarcoidosis. And then when it comes to vaccination, so particularly relating to the COVID-19 vaccine, in the article I covered, they mentioned that thus far they don't have any cases to report on as yet. However, they looked at other vaccines. I think they mentioned the flu vaccine and so one other vaccine, I just can't remember which one it was that they looked at specifically, but what they realized was that in patients who have sarcoidosis, so some of them didn't mount an adequate immune response. And yeah, so in the other vaccine, which was the flu vaccine, they found that sarcoidosis mounted an immune response which was as equivalent as the other patients who didn't have the presence of sarcoidosis. So the data is somewhat it's conflicting at the moment. And So in sarcoidosis patients, isn't a lot of them would be on drugs. So either your corticosteroids, your immunosuppressives, or even the biologics. What they did was that certain protocols have been released where, say, a patient is on corticosteroids. So if you're taking 40 milligrams, then around the time that you vaccinate, ideally you would decrease the dose perhaps to about 20. And with the immunosuppressives, so on the particular day where you would have taken the vaccine, then you would miss your dose of the immunosuppressive agent for that particular day. And with the biologics, so that it's given, I think, on intervals of about 6 months, so about 4 weeks before the next dose and 6 months of the previous dose. Again, you just allow certain time frames. So those were the difference that I read on that differentiated on how you manage a patient who would have sarcoidosis to another one who wouldn't.
Okay, thanks, Sama. Yeah, it is obviously, there's a lot of unknowns, at the moment with COVID-19, and there's also conflicting aspects. We have to look at the management and what medications they're on, as well as the unmanaged, initially managed cases. I think there's a question. There's two questions. One is, has the histology been checked up under a reflex microscope for particles as can be found in lip-stiff cream? So
can you maybe phrase that differently?
I'm not sure. Perhaps the attendee could just rephrase that. But I obviously assume that you would be following protocol in terms of histology with granulomatous conditions, and perhaps they're not going to be specifically looking for something as specific as this. But perhaps the attendee can rephrase that. And the next question is, what is the prognosis amongst documented cases of sarcoidosis?
Okay, so with a greater number of the cases, they often resolve spontaneously, but again, it would depend on the organs involved, like how many there are and how extensive it is with those involvements. But a lot of cases have been shown to resolve spontaneously. I think about 60% from my presentation, and very few of them actually result in death of the patients. And this would be perhaps from the extensive fibrosis, which could develop, restricting organ function or even impinging on certain vital structures. So yeah, about 60% of them resolve, and only about 4 to 10% tend to die from the extensive involvement of the sarcoidosis.
Thanks, Sama. Sorry, the other question, has the histology been checked under a reflex microscope for particles? I assume that would be related to, actually considering again, a foreign body reaction, foreign body granuloma. So, I mean, which may form a part of your differential for granulomatous conditions. But I assume in this case, there are other clinical markers that you looked at and other clinical evidence to suggest sarcoidosis. And it's just not a non-caseating granulomatous condition on its own. You've put together all the other pieces of the puzzle to come to the diagnosis. The next question is, will ivermectin work against sarcoidosis? Do you expect complete resolution?
I think I'd have to check on that one. I'm not sure.
Okay, so I mean, you could, I could ask the attendee that they could email you directly, and you could provide an answer for that.
Okay.
All right. All right, thank you. I think that's all the questions for this evening. And yeah, we appreciate everyone's attendance, and we thank you on behalf of the South African Dental Association and the South African Society for Periodontology, Implantology, and Oral Medicine. Thanks, Amma.
Thank you very much, Doc.
All right.